Yes, just buying time. A reminder, please keep your microphones muted. And then also, if you have any questions or comments, please make use of the chat room. And most of your questions in the chat room will be responded by Dr. Amtire Maureen. Okay. Yes, so in 2 minutes, we shall start. All the presenters are set. And anytime from now, in the next 2 minutes, we shall be starting. Yes, I'm seeing in the chat room, people are saying good afternoon, good afternoon. Indeed, it's a good afternoon. You can't hear me? Jen, are you able to hear me loud and clear?
Yes, we hear you
Jen.
well.
Okay.
Yeah.
Yes, you're loud and clear.
I just saw someone in the chat commenting that my voice is low, so maybe it's on their end. Okay, just 2 more minutes. We're just buying time to allow some of our colleagues who could be wrapping up some of their activities here and there to join us. So in 1 minute, we shall start. Yes, thank you. Yes, people are saying that I'm loud and clear. Thank you. Okay, so we are going to start in the next 1 minute. Those who have just joined in, we are chosen to give 5 more minutes to our colleagues to join us. Okay, thank you. Yes, you can hear me. Thank you for giving that feedback. Okay, so it's 5 minutes past 2, and we can start. So I welcome you all to this webinar. Yes, I'm Elizabeth Najingo, a CPD chair for the Uganda Pediatrics Association and an associate consultant pediatrician. So Uganda has the third highest global burden of malaria cases, and it accounts for half of our patients' visits. So if you're to find 10 patients in the queue for an outpatient visit, half of them, that is 5 of them, will be suffering from malaria. So severe malaria still remains an important problem in children below 5 years, though we are now seeing increasing numbers in older children. And school-age children and adolescents, that is 5 to 17 years, have emerged as a primary target for severe malaria mortality. So as some of you know, we have just lost 3 teenagers in secondary schools around Kampala. So this has been a sad season, and I think most of you have been encouraged to join this webinar to find out more about what's happening. So this trend is heavily driven by a lack of targeted interventions. You find that school-age children are rarely prioritized for distribution of mosquito nets, and they spend evening hours studying or socializing outdoors where mosquitoes bite, okay? As you know, boarding schools or, yeah, most of the schools, I mean, and it's normal. Children have to go out and play and interact and engage in sports and do preps, you know, okay? So because of that, the vectors, that is the mosquitoes, meet them and they bite them. And most of the times, these children or these older children or adolescents are frequently misdiagnosed due to unusual clinical presentations. Okay, so compared to the children who are below 5 years, the presentation of that age group has been well described in literature, but this age group has sometimes unusual clinical presentations, so they are quickly missed out. So as the Uganda Pediatric Association, we received reports or challenges facing our preferred option of treatment, which is artesunate. So these challenges include a possibility of drug resistance and delayed parasite clearance. So it is upon this background that the Uganda Pediatrics Association, together with Ministry of Health and World Health Organization, decided to refresh our knowledge regarding severe malaria treatment in children and adolescents. So this will enable us to unlearn certain practices and eventually learn evidence-based facts. So I now invite the first speaker, and that is Dr. Jane Achan. She's a principal advisor at the Malaria Consortium and a practicing pediatrician. She's a medical doctor with a PhD in biomedical sciences, a master's degree in pediatrics and child health, and postgraduate training in clinical trials. So with over 20 years of experience in clinical and operational research, her work focuses on malaria, maternal and child health, and health systems research to inform policy and practice. She serves on several national and international advisory committees, including the World Health Organization Malaria Policy Advisory Group. So welcome, Dr. Jane, to take us through the first presentation.
Thank you, Elizabeth, and good afternoon, everyone. So this afternoon, I'll be sharing with you an overview of what the current global guidelines are for severe malaria case management in children. And as I've been mentioned, I work for Malaria Consortium. So we do know that malaria is a life-threatening medical emergency and it requires immediate hospitalization and urgent medical attention. Unfortunately, more than 95% of malaria deaths occur in Africa, and as Dr. Elizabeth has mentioned, this is largely in children under 5 years of age. But more recently, there is an escalating burden in older children that has been reported across different settings, not just in Uganda. And the reasons have also been alluded to: declining immunity, but also suboptimal coverage of the current control interventions. There are many malaria parasites, but Plasmodium falciparum is responsible for most of the severe cases of disease that we see in Africa. It's also important to note that mortality or death ranges from 10 to 20% of everyone who comes down with severe malaria, even with optimal treatment, and this increases substantially when there is any delay in treatment. So really, quick treatment and prevention are very important. Now, what is severe malaria? There's been a lot about severe malaria, but what is severe malaria? So severe malaria is really a constellation of many symptoms or symptomatologies, and it's really a person presenting with one of the following, and this should be occurring in the absence of any other identified alternative cause and in the presence of P. falciparum asexual parasitemia. So you have parasites, you don't have any other explanation for the cause, and you're presenting with any of the following. So one is impaired consciousness, or what we call cerebral malaria in many settings. And these are children who have a very low coma score. If you're using the Blantyre coma score, it's less than 3. And for the Glasgow coma score, that's about less than 11. Then we also have the clinical condition called prostration, where there is significant weakness. A child is unable to sit, stand, or walk without any assistance or without support. There's a clinical entity that is multiple convulsions, and this is said to occur when a child has 2 or more episodes of convulsion within a 24-hour period. For hypoglycemia, we look at a blood or plasma glucose level of less than 2.2 millimoles per liter, or if you have another glucometer, less than 40 milligrams per deciliter. There's also severe malaria anemia, where you have an HB concentration of less than 5 or a hematocrit of less than 15 in children less than 12 years, with concurrent parasitemia with more than 10,000 parasites per microliter. There's pulmonary edema, which is a lot more common in the older children. You can confirm this either on X-ray, or the patient presents with an oxygen saturation of less than 92 on room air, or respiratory rate of greater than 30 with chest indrawing and crepitations. Hyperparasitemia is one of those most common amongst the children we see, where more than 10% of the red blood cells have malaria parasites. So hyper means very many parasites for the lay audience that may be in here. Then there is renal impairment, which I won't dwell much on because Dr. Bate will be talking extensively about that. Then we also have episodes where unusually, there's also bleeding, which may either be recurrent or prolonged. It can come from the nose, the gums, the veins. They may vomit blood or have melena, but they may also have blood-stained urine that is also increasingly being seen, especially in the older children. Finally, there are also a category of acidosis where there is a base deficit of greater than 8 millimoles or a plasma bicarbonate level of less than 12. And usually at the clinical level, severe acidosis presents as respiratory distress with rapid, deep, and labored breathing. We have jaundice as an important clinical manifestation where the bilirubin levels are greater than 50 micromoles per liter in the context of a parasite count of greater than 10,000. And of course, we also have shock, which can either be compensated with delayed capillary fill and normal blood pressures, or decompensated where you have systolic blood pressures that are lower than about 70 milligrams of mercury in children. Now, I also thought I should highlight an important clinical entity that seems to be causing a lot of problems in the children, the older children and adolescents. There is an important group of children who present with what we call uncomplicated hyperparasitemia. So they have high parasite counts. These are patients who have more than 4% of their red blood cells parasitized with malaria, but they do not have any signs of severity. So this is the child who would walk into the clinic, you would take a blood smear and find this level of parasitemia and send them home. These patients are particularly a significant problem because they have a high risk of rapidly developing to severe malaria, and they also quickly get treatment failure. And they also, for public health perspectives, are considered an important source of resistance. But it's very important, if we look at a lot of the cases we've seen in the secondary schools that have been reported, these are children who presented with headache, but high parasite counts, and were given an ACT and basically sent away. So these children should be monitored very, very closely in addition to receiving the oral antimalarials, because there is a rapid progression from a seemingly non-severe illness to very severe illness, and sometimes with limited time to intervene. So now that we've talked about the clinical presentations, how is malaria diagnosed? The gold standard for diagnosis is ideally microscopy, because microscopy helps you quantify the number of parasites that are present in the blood. But of course, in settings where we do not have microscopy, the rapid diagnostic tests are also used. Additional investigations are quite important because they help you really do a holistic assessment of the patient. So full blood count, blood glucose, the blood gas lactate, urea, creatinine, electrolytes, liver function tests. If there is suspicion for septicemia, we do blood cultures and of course cross-matching, grouping and cross-matching, and urinalysis to be able to make a good diagnostics, but also exclude alternative differentials. Despite the fact that we need to do all these tests for evaluation, treatment must not be delayed. So we do not wait for the lab results before you initiate treatment. Timeliness is critical for severe malaria, as we will see. So once you suspect severe malaria, you're conducting the investigations, please start treatment immediately. Now, in terms of treatment, for severe malaria, the main objective of treatment is to prevent that patient from dying. If we do not remember anything, let's remember that today. The main objective of treatment is to prevent the patient from dying. Of course, there are secondary objectives. Apologies. The secondary objectives are to prevent disabilities. So basically all those complications that may arise, we want to prevent those disabilities, but we also want to clear parasitemia such that there is no recrudescence or recurrent infection. And particularly for severe malaria, death occurs within hours of admission. So it's really critical that we have those therapeutic concentrations of effective drugs achieved as much as possible. So in terms of management, we will look at it in 3 categories. And of course, the next presenter will provide a lot more detail around this. So we do a clinical assessment of the patient. We provide specific anti-malaria treatment, but we also provide additional treatment and supportive care. So in terms of the initial management, we have the standard ABCDE approach. We need to assess the airways to ensure that the patient is breathing well, the patient is positioned in such a way that the airway is protected. If they are comatose, we facilitate respiration by intubating and ensuring that we are breathing well and the airway is protected. Looking at the breathing, we do a pulse oximetry to see the levels of oxygen. If the levels of oxygen are low, we provide oxygen, and then we also monitor the work of breathing to ensure that breathing is also fine. Then we also assess for circulation. How is the perfusion? Fluid balance is quite critical in these individuals, so we avoid aggressive fluid management and establish IV access as is needed. It's also critical to be able to assess for any disability. What is the coma score like? What is the blood glucose? What are the liver function tests? Is this patient having convulsions? So it's important to assess for the disability as well. There's also what we call the E, where there's exposure. You assess for temperature, you assess for level of hydration, but you also assess whether there's a rash. Remember, there could be other potential differentials. So assess if there's a rash that could indicate another alternative diagnosis. And critically for children, we also weigh them because all the medication is based on the weight. Now, briefly about anti-malaria therapy, and I know there have been lots of discussions in the community around what drug to use, but according to WHO, and as you'll hear from the next presenter, national guidelines, our first line of treatment for severe malaria is injectable artesunate. This is given at 2.4 milligrams per kg, either intravenous or intramuscularly. But for children who are less than 20 kilograms, I think this is important for the clinicians here. The dose is higher. That dose is 3 milligrams per kg because these children have a larger volume of distribution, so they need a larger dose to be able to achieve the equivalent drug concentrations to be inhibitory for malaria. So that's kind of a difference between the 2 categories of children. Then there's also another issue that brings a lot of confusion. How do we administer injectable artesunate? So the administration should be at 0 hours, at 12 hours, and at 24 hours, then every 24 hours until oral therapy. Regardless of clinical improvement, injectable treatment should continue for at least 24 hours. I think in a lot of fora, you will hear clinicians mentioning they got 3 doses. No. That treatment should continue until the individual is able to tolerate oral therapy and for a minimum of 24 hours once you've started the injectable. And we do have evidence that actually supports the use of injectable artesunate. So there was a large study across 7 African countries called the Aquamat study. This is the largest ever study that was done for severe malaria. And in that study, it did show that mortality, death, was significantly lower, about 23% lower in children who received artesunate compared to those who received trinine. And that is what informed that guideline. And then there's also been a lot of discussion and concern around resistance and potential delayed parasite clearance. We are tracking those concerns with the program and the different academic institutions. But a recent study that was done in Uganda did show that even among children who had mutations that suggested resistance to artemisinin, the clinical outcomes were not worse. So this initial observatory study actually does provide assurance that the first-line drug in these settings is still fine, but we are continuing to evaluate the potential impact over the years with surveillance across board. So a bit of reassurance that artesunate does work. Jen will be going through the administration aspects in more details because I think sometimes the quality of administration of these drugs also impact on the clinical outcomes. So in terms of parenteral anti-malaria drugs, these should be given until the patient can tolerate oral medication before we give any oral follow-up, and particularly for a minimum of 24 hours, irrespective of what the patient's ability to tolerate oral medication is. So if you give a child one dose of IV artesunate and they're able to tolerate oral medication, please complete the 24-hour duration. It's been shown that parasite clearance is better and clinical outcomes are better once those initial 24 hours are covered by the injectable artesunate and the drug. So once they're able to tolerate oral medication, then you complete the dosage with a full 3-day course of an artemisinin-based combination therapy. So globally, of course, there are different alternative ACTs, but when we listen to the country program, we will see at the country level what are the recommended oral ACTs that we continue with. And of course, these oral follow-on therapies are important to be able to completely clear the residual parasites. Artesunate is rapidly acting, so it drastically reduces the parasite load, but those remaining parasites are then cleared by the oral medication that we give after the injectable course is completed. Now, there are other alternatives to artesunate when artesunate is not available, and these alternatives are either artemether or quinine. According to WHO, the preference is artemether first, then quinine. Artemether is oil-based and given as an intramuscular injection. The initial dose is 3.2 milligrams per kg, and the maintenance dose is 1.6 milligram per kg. And then, of course, we also do have quinine given at a loading dose which provides that therapeutic concentration within 4 hours and then given a maintenance dose. If a patient has not improved within 48 hours, we need to step down the dose of quinine to about a third. And then, of course, critically, the administration rate must be slow, given usually in 5% dextrose, and that should be infused over 4 hours. For those that have devices that can monitor the rate, it should not exceed more than 5 milligrams per kg. Now, it's critical that continuing supporting care is done. Actually, continuing supportive care is as important as the anti-malaria medication you give. Ideally, in an intensive nursing unit, or an intensive care unit, or at least a high dependency area because of the rapidly changing clinical situation in these patients. So clinical observations need to be done very quickly, monitoring the vital signs, the coma score, fluid balance, but also the urine output. Blood glucose is very important. If we could monitor that every 4 hourly if possible, but particularly in patients who are unconscious. And of course, evaluating for the other manifestations of severe disease or severe malaria is quite critical because the situations change. So track the parasite clearance, track hemoglobin, look at lactate, but also monitor the electrolytes going forward. There are other management aspects. So there's also immediate clinical care for all these complications. So coma, hyperpyrexia, convulsions, hypoglycemia. These are going to be explained in detail by the next presenter. So I'll not go through this in detail, but it's critical to see that there are many moving pieces. So you do not focus on the anti-malarial drugs alone. You also continue with all the other clinical manifestations that the patient is presenting with. But Dr. Jen Navakoza will be going through these in detail, so I will not go through that, but critical to keep an eye on all these multiple manifestations. And then there's also this critical issue of concomitant use of antibiotics across our settings, and there are some general guiding principles that WHO provides. One of the things is that the threshold for administering antibiotic treatment should not be low because there's significant overlap between septicemia and severe malaria, and sometimes there's a diagnostic challenge in the different facilities we work. So do have a low threshold for administering antibiotic treatment in those settings. Broad spectrum antibiotics should generally be given until such a time that bacterial infection is excluded. And after you start an antimalarial drug, any unexplained deterioration may actually result from a supervening bacterial infection. And commonly in patients with severe malaria, salmonella seems to be the predominant problem that they have. So that's something that we need to look out for. The other clinical aspect is, of course, as part of the improvement trajectory. They may be aspiration, they may also be secondary pneumonia. So those should also be covered with appropriate broad spectrum antibiotics. Any persistence of fever despite parasite clearance, and I know in our WhatsApp groups we've been talking about poor clinical improvement, but if there's a persistent fever and the parasitemia has cleared, please look for other causes of fever. Does this child have a UTI? Does this child have another systemic bacterial infection? It's very important. And of course, one of the other general principles is that antibiotic treatment should be ideally governed by culture and sensitivity results. If these are not available, then it's really the local antibiotic sensitivity patterns that govern the choice of antibiotics. When do we discharge these children? We should discharge children when they are febrile, ideally when they've completed the oral ACTs, which may not be a practice, when the parasites have completely cleared, when these patients are feeding adequately, of course, when the patients have normal consciousness, they should have a stable hemoglobin, and importantly, the caregivers should be counseled on follow-up and prevention. Prevention, I think, is quite key, and the caregivers should be counseled, and the Ministry of Health presentation will talk a bit on prevention. And then, of course, the discharge must be a smart discharge, and the next presentation will provide additional information on what smart discharge means. So the key messages from this first talk is that severe malaria is an emergency that requires immediate treatment. Injectable artesunate is still the global standard of care, but we must use this drug the right way, and the quality of drug also must be appropriate. Once we've finished parenteral treatment, we need complete therapy with a full course of an oral artemisinin-based combination therapy. Supportive treatment is critical. It's as critical as the anti-malarial therapy. We need to correct hypoglycemia, we need to correct severe anemia, we need to treat seizures, and we need to carefully manage fluids. And finally, early recognition is key. In these schools, how is the treatment provided for severe malaria? Early recognition is key. Protocol-driven management is key. Do we have protocols that the school nurses are using for treatment? And intensive monitoring significantly reduce mortality. So if we are able to do this, I believe that we will contribute to significant reduction in morbidity and mortality that we are currently seeing with severe malaria. So thank you very much, Elizabeth, and over to you. I'll stop sharing now.
Thank you, Jen. In the meantime, Dr. Jen Nabakoza, you can be loading your slides as I make a few remarks. That was brilliant. The audience is thrilled. Yes, as we've all heard, Dr. Jen Achan has emphasized to us that malaria is real. Okay, it is real. And our goal when it comes to management of severe malaria is avoiding death, avoid death. Don't let anyone die from malaria. So how do we achieve that? Early recognition. Early recognition. Remember when we were starting, we said that as the children get older, their presentation is a bit unusual as compared to those who are below 5 years. So we need to learn how to recognize malaria among the older children, those who are above 5 years up to 19 years of age, okay? And she has also emphasized that artesunate is still superior, okay? So artesunate is still superior over quinine. Okay, so she has laid the ground flat for all of us. And I want to recognize the fact that we are now a large audience. We are over 1,000 of us online. And because of that, we secured a YouTube live streaming channel. So don't feel anxious when you see the link full to capacity. Those who are logging in after the maximum capacity of 1,000 are being diverted to the live streaming channel on YouTube. And with that, I also want to recognize that we are having several stakeholders in attendance of this webinar. That is different people involved in childcare and advocacy, starting with the parents, okay? Yes, I recognize some parents who have logged in. I know most of you, it's been because of the current panic that has been going around. Yes, we welcome you and we know that you're there and the presenters have you in mind. Don't think we've neglected you and only take talking to ourselves, the health workers. We also have teachers and of course healthcare workers of different levels and specialities, and definitely policymakers at different levels. So we welcome you all, and please post your questions in the chat section. Dr. Maureen Amtire is doing a good job responding to all of them. And for those that she feels need to be answered to directly by the presenters, we shall do it at the end, okay? And for the health workers, please fill in the link for registration for CPD points. It's within the CPD chat. So I welcome Dr. Jane Navakoza Irene from Ministry of Health, Department of Communicable Diseases, Prevention and Control, National Malaria Elimination Division. So she's a pediatrician and public health specialist. And she's within the Division of Case Management, and she's also the technical lead of malaria chemoprevention and vaccine. She has been hunting and dreaming and talking and drinking malaria. So malaria is her specialty for the last 18 years. And with that, she has served in various capacities. So Jane Navakoza, we welcome your expertise. Please go on and start your presentation. Jen, are you there? If you're talking, please unmute. Dr. Jen Navakoza? Dr. Jen Navakoza, we can't hear you. Dr. Chan, are you able to hear Jen?
No, she's not audible.
Jen. And I'm not even able to see her online. Has she dropped off? She's gone off. She's gone offline. Maybe she's trying to reconnect. Dr. Anthony Bate, are you there? Dr. Bate? Dr. Bate, are you there?
Yes, I'm there. I don't know that you're hearing me. Would you want me to
Yes.
present?
I think, yes, you should present as we sort out technical issues happening to side with Jen Navakoza. Is that okay with you?
Yes, very fine.
Yes, so please start your screen sharing as I talk a little bit about you. Yes, so Dr. Anthony Bate he's a pediatric nephrologist. So to the parents online, he's a kidneys doctor. He's a doctor for kidneys of children, and also a senior lecturer at Makerere University College of Health Sciences. So we are going to have his presentation first as we try to link up with Jen Navakoza. You're welcome, Dr. Bate.
Yes, thank you, everyone. And I'm happy to be here. So, and I'm happy for the audience. Unfortunately, much of the content may be directed towards the doctors and the nurses and the medical team. But the parents, if you're not covered, don't worry. I think this is the only thing you may miss. Otherwise, every other content will for sure be fit for the audience. So Here I'm going to talk about management of acute kidney injury in children who have severe malaria. But before I go to acute kidney injury, how we should manage it, we are going to define it. And so this is when the kidney stops working, abrupt loss of kidney function. You will realize currently there are new updated guidelines that have come up. They don't differ so much when it comes to us, what we've been practicing, where we've been defining acute kidney injury as a change in serum creatinine of 0.3 milligrams per deciliter, which is equivalent to 26 micromoles per liter from the baseline, or a 1.5 times change in creatinine. So a child, if today's creatinine is 20, if tomorrow creatinine is 40, then there's acute kidney injury because creatinine has multiplied by 2 times. In the new guidelines, they are proposing to add other biomarkers, but these are probably mostly for research. So they are not going to take us so much off from the guidelines that we know. And as you've realized, kidney injury or failure of the kidneys to work is one of the complications of severe malaria. So we should be able to look out for the acute kidney injury. Remember, we can also tell acute kidney injury from reduction in urine output, which should be a quick one for us to pick out children who will require blood testing and further management. So to understand how we treat the acute kidney injury, so children who have kidneys that have stopped working, we should first understand how does this come about. So first of all, it is a common problem in about 35 to 46% of children who have severe malaria. Their kidneys or creatinine may change to meet the criteria for AKI or acute kidney injury, even though it may not be very severe. And so about 10 to 15%, they may get severe AKI. So what happens for malaria to cause acute kidney injury? One, it's because of the impaired perfusion or the blood reaching the kidneys. And this is pre-renal injury because these children are dehydrated, they are vomiting, they have diarrhea. So this is one of the mechanisms in which then the kidney, the blood supply reaching the kidneys reduces, and therefore we get AKI. So that's one of the mechanisms, hypovolemia, because the kidneys are not getting blood from the dehydration that comes from diarrhea and vomiting. However, malaria on its own can also cause the endothelial and immune activation, something that how you would see what happens in sepsis, causing cytokines to increase and then vasodilatation. All this may cause dysfunction of the kidneys. But also we know that when malaria infects red blood cells, these red blood cells become sticky. So they start clogging the blood vessel, especially the small capillaries. And they stick to the capillary membrane. So they cause cytoadherence in the microvasculature and the small vessels. And also they can form rosettes. So the infected red blood cell can stick on the non-infected red blood cells, forming clumps. Now these clumps will also cause obstruction of the blood supply in the kidneys. So rosetting, cytoadherence, all these can block the vasculature. And then the inflammatory response can also lead to tubular injury. The fact that there is active inflammation taking place, activation of the immune system, then the production of, because the red blood cells that are infected with malaria, they start breaking down the cell-free hemoglobin. So hemoglobin shouldn't be out of the red blood cell. That cell-free hemoglobin causes oxidative stress and injury to the kidneys. So oxidative stress, removal of nitric oxide, causing vasoconstriction. So many of these pathophysiological mechanisms will lead to reduced blood flow to the kidneys. So the mechanisms are many, from the parasites, the hemoglobin, cell-free hemoglobin, and the hypovolemia. The child because the children are not drinking and they are vomiting. So therefore, how should we manage? Now, there is this publication that's already available, which you can come up or look. We wrote it, and it was majorly on management of infection-associated acute kidney injury. But it also works well for malaria. What we should do is every patient, if you see the first green, yellow, and those levels, every patient who has no AKI, we should treat the infection. I think that's what Dr. Chan was talking about. We should quickly treat the infection, get the infection away. If we realize the child is at risk of AKI, so for example, they are vomiting, they have a lot of diarrhea, so there's already a risk which is increased. Then we should start thinking about kidney protective care. We should start protecting the kidney because we know malaria is a risk for kidney injury. So we should now stop the drugs that are nephrotoxic, the use of non-steroid anti-inflammatory drugs, the brufens, diclofenacs. So this time now we start limiting them. And then we should rehydrate the patient. As you realize, with artesunate, we just give the medicine. And Dr. Chan has told us already, not only should we focus on the medicine, we should also focus on the complications. So we should start thinking about, but is this child's volume status adequate? We should start rehydrating the patient. Then start monitoring. Is the urine output adequate now? And that's a quick one where I don't even need labs. So everyone should be monitoring that. Then when we realize, or when we are able to check the creatinine or kidney function tests, and we find AKI, now our mode should really change to start the kidney care. And usually sometimes the staging, when you look at the change in creatinine, sometimes it's not so much. So we are either in stage 1 or stage 2. So meaning if we can stop the drugs that will likely cause AKI or worsen kidney injury, this is the time we should start thinking about them, either removing them or adjusting doses when they are completely needed. But if the kidney injury becomes severe, then we should start also making phone calls and involving the nephrologists. As everyone is aware, most likely the patients are not aware, the kidney specialists are not many, so don't say, but where is the nephrologist? No, the team we always talk on phone, and then we can always still discuss and come up with a plan of then how do we manage the child, even where they are, wherever they are. We don't have, doesn't mean complete referral, but the doctors, you should now be able to judge, do we need to refer or discuss with the specialists? Do we still continue to keep the child and monitor, remove the causes so that we see if the kidney improves? Because referral usually is done when we either have progressing kidney injury or we need specialized care like dialysis, so that we can initiate it in time when it's needed. But the backbone of the management of acute kidney injury is to ensure that we remove the cause. So if the cause is malaria, we just have to keep treating the malaria well. If there is any additional infection, we should also look for it and make sure we treat it. If there's diarrhea or whatever, these are precipitating factors. Some people are using herbs, so this is the time to talk to the caretaker and tell them not to use the herbs, because these herbs will also harm the kidneys. So when there is AKI, when you see change in kidney function, this is when we should now really be strict on the caretakers to remind them of not adding more herbs or harm to the child. And if there is dehydration, we should take it away and ensure the volume status is adequate. And then even when we are doing investigations, then we should take precautions that are adequate to ensure that we are not harming the kidneys. Then for fluids, one of the things that commonly comes up, so I always make a presentation on these same things, is then how should we manage fluid in the child who has acute kidney injury? Should we give a bolus of fluids? Should we give fluid challenge? Should we give Lasix? What should we do? Essentially, every patient, there is no one single rule that we give for every patient with AKI. So each patient, you need to direct their fluid management based on their presentation. If a child is dehydrated, even if you're not seeing urine, you don't have to give Lasix. The whole thing they need this time is fluid hydration. So you should hydrate them so that the kidney can pass urine. Or so that the child, in fact, so that you can even stop the progression of the kidney injury. So if the child is not swollen, the child is dehydrated, then our target should be to rehydrate them. Use the appropriate plan based on the status of dehydration. If they need plan A, they need plan B, they need plan C, or they are in shock, then you manage based on the guidelines for fluid management. Then, if the child is edematous, that is, if the child is swollen, then we should restrict the fluid. In this case, the kidney has said it is locked, so there is no more room to add more fluid. Now, this is a patient, if you want to take away the fluid, then you can give Lasix, because now the child is fluid overloaded. And those who are normal volemic, so they are not dehydrated, they are normal volume, so, or euvolemic, then you don't have to do any fluid restrictions. You just need to keep giving them the feeds, ensuring that the volume status does not reduce as you treat the cause of the AKI. So some children have a lot of polyuria, even when they have AKI. So you just keep adding fluid, provided there is no volume. So if the urine they are passing, even when they have AKI is a lot, you just add more volume. But there are those, for example, who are edematous, they are very fluid overloaded. That's when we go to replacing insensible losses. And sometimes if there's no urine output, if there's some urine output, then you have room to add more fluid. When there is completely no urine, then it means the only fluid we can give them is insensible losses. But that in practice can be hard, that when you calculate the insensible losses, then you're not meeting the rates of the drugs, the hypoglycemia, and so sometimes this can be an indication for dialysis. The other common complication that is always an emergency is the hyperkalemia or high potassium levels. And the management is always the standard management, where we give IV calcium gluconate to stabilize the heart, to give insulin glucose or insulin dextrose to lower the potassium, and this makes the potassium go into the cells. But remember, for smaller babies, or when the baby is not feeding, when the child is not feeding, this insulin can cause hypoglycemia. So as you're giving insulin, watch out if you can measure the blood sugar levels. If you are unable to measure the blood sugar levels, the insulin alone may cause more risk, may kill the patient before even the kidney or the potassium. So boluses of glucose alone. Remember, every time in normal state, if the liver is working, if we bolus with the dextrose boluses, the liver will produce insulin. So if the liver is okay, is working well, then boluses of glucose can also do the same. Studies have showed, especially this has been in observational studies, this also lowers potassium, although the rate of lowering may not be as fast as or as high as the one of insulin, but it's better. In neonates, don't even try giving insulin. They will get hypoglycemic. So you're better off doing the glucose boluses. Then you can nebulize them with salbutamol. These effects last for 4 to 6 hours, so you may need to repeat. Apart from calcium gluconate, you don't have to repeat, except if you have potassium levels, calcium levels For it, if the calcium is normal, then you don't have to cause hypercalcemia. But insulin glucose, nebulized salbutamol also lowers potassium, but you need to repeat that. Sodium bicarbonate is a good one. It helps, especially when there's acidosis. But avoid boluses of sodium bicarbonate because they can cause respiratory failure, or they can cause the child to stop breathing. So what you need to do is you give it very slowly, to ensure that you don't get into that problem. But there are salts for the calcium, kioxalate, which you can also give either by energy tube. Sometimes we mix it in milk, and then it lowers also the potassium. Furosemide is also a good drug for lowering potassium. But most key of all is you should lower the intake of potassium. You should reduce the potassium feeds, the feeds, you should only give the feeds that have low potassium. Sometimes we have troubles with the standard pay feeds. You may have your own list of feeds that you think this has low potassium, but the patient comes to you, especially children, and for them, they have refused all foods. They're telling you even strange foods they want to eat. So it's a bargain. For you, what you can do as a doctor to know, therefore, is this food, should I just stop it all because the child has refused to eat? Or can I check up the potassium content? Google does that very well. So if you just put potassium content per 100 grams, you can see, for example, ground nuts have very high potassium. So you can compare that with bananas. If you can see banana, that's one of the things that we know always has high potassium. So it's one of the restricted foods. You just check by per 100 grams. You can see bananas have 358, groundnuts 705. But if you check rice, white rice or rice, white rice, it has just 35 milligrams. So meaning you can, if a child tells you, I want to eat what? Pineapple, or I want berries, you just put it in here, compare. How does it differ from rice? How does it differ from bananas, which is usually our red line? Because we rarely have renal dietitians to help you out. And sometimes you find a village, and they are telling you they are eating different foods. Others want to take kashera, others want OD. So you want to be able to use Google sometimes, not all the time, but sometimes it can help, or you can always consult, and then we discuss the fits. But this is one of the quickest approaches. And then sometimes if the kidney disease persists, or you can even create your own list nearby. Sometimes a quick one, which I do that many times to get for patients. As you can see, I think this was one of the patients. They had given me whatever they want to eat. Then I punch it in Google. Already some of them I know. And sometimes I keep updating my list. Whatever they mention, you Google and put what has low potassium, which one has high, and then you can always use that list and then keep adding or reducing. This happens a lot when the kidney disease persists. If it stays for a short time, you may not struggle a lot with food, but if it stays for longer, the children will get wasting. When a child says, I don't want posho, you will struggle because they have said no, and sometimes it's hard to feed them. So these are some of the tricks we use to ensure that we get them. Now, I'm only mentioning another electrolyte that is also risky, and it's common in AKI, but also linked to mortality. So some children or some patients have hyponatremia, low sodium levels. And sometimes we are also making it worse by using furosemide. Please remember, I think just want to make sure that we always remember that if we manage hyponatremia badly, we are at risk of causing osmotic demyelination syndrome, or what you used to know as centropontine myelinosis. And sometimes this can also can be a risk for death. So the principle of managing sodium is to know whether it's acute or chronic. But these, knowing them or not knowing them, you should go for the safest approach. Always And this, in the end, actually, whether it's acute or chronic, you realize in the end, potassium is never corrected quickly. This is now becoming commoner because we now have hypertonic saline freely available, especially in very good hospitals. So please don't give people boluses of sodium to just make sure the sodium comes back to normal. We should follow the principles of management of hyponatremia to avoid an unwanted deaths. So one, we should calculate the sodium deficit, which is you multiply the body weight times 0.6, set your desired sodium that you want, and the current sodium. That is the difference between those two is what we are talking about here. It should not exceed 10 to 12 millimoles in 24 hours. After you've set it, in a neonate, because this is 0.6 times weight is total body water. In a neonate, you may use 0.8 because for them, their total body water is 0.80% of the body. So I gave an example here. If I have a 10 kilogram child, the sodium is 115. I multiply 10 times 0.6. If I want, you set the desired sodium is not static. You will get into some textbooks. There will always, some textbooks have a 135 there. So that's the wrong thing, approach. Because the desired sodium minus the current shouldn't be always static. If I put it at 135 in this patient, it means I will correct by 25 millimoles. That's a lot. So you should set a desired sodium to be not further than 10 to 12. Then you correct. If you get the value like 60 millimoles of sodium, then now decide which volume to use. Whether you're going to use hypertonic saline, now we go back to our mathematics of O level and A level. 3% saline has 513 millimoles. If I want only 100, if I want 60 millimoles, then I do 60 times 513 divide by 1000 and I get 117. Then that 117, I use a fluid pump. Again, I don't bolus it. A fluid pump is easy to set. We will set 4.8 mils per hour, then it goes in. You can use any solution, whether you've used normal saline or Ringer's lactate, you just do the same calculation. But we understand that fluid pumps are in, especially in the big hospitals, but not every lower health facility. Even in the big hospitals, we struggle. Sometimes we can use the teaspoon of salt to correct the sodium. A small teaspoon of salt, which is not heaped, has 104 millimoles of sodium. So if I mixed it in 100 mils of water, it means I have 100 millimoles of sodium, which is 1 millimole per meal. So if I want a child who required 60 millimoles, I put there 60 mils. Then I just give them 60 mils in 24 hours. And I can use an energy tube. This is not standard practice, so don't go international and say now we've discovered something new. This is to improvise for our setting. Where we don't
Dr.
have...
Bate,
Yes.
you have 5 more minutes, please.
Thank you very much. And this is, I think, the second last slide or third last. So don't give, you can always use oral salt. You don't have to struggle, but it has to be measured. Then you only refer to us, or you only refer patients for dialysis, or we only decide that we should do dialysis when we have the indications, which for the doctors you're aware of, the hyperkalemia, not responsive to care, metabolic acidosis, fluid overload, and uremia. And the number of considerations we consider, but this is probably for us when we are conducting dialysis, where we do either hemodialysis or peritoneal dialysis. And this can be done in smaller children, in bigger children. So this, and it can be done in any facility, although with limitations. So where they can do the dialysis, they can also do peritoneal dialysis. So essentially what we are saying is acute kidney injury is a common complication of severe malaria. And this is one of the risk factors for death in children or for mortality. And sometimes even after we've discharged patients, this can be recurrent and also recurring with the malaria. So that's why the smart discharge comes into play to still prevent these complications. And when indicated, we do the dialysis. Thank you very much.
Thank you, Dr. Bate. That was quite focused and very clear. So I'm seeing some hands up. I'm sorry, Dr. Anne. We are going to have the questions at the end. We have 2 more presentations. I'm seeing Dr. Jane Navakoza is back online. Please load your presentation. Yes, Dr. Navakoza had an internet hiccup and she was logged out of the meeting because we are full to capacity. So she had to struggle to be put back into this meeting, but now she's back. Dr. Jane, you have 15 minutes for your presentation. Please start.
I'll not recap for where Dr. Jane highlighted. Important is that clinical assessment is key, comprehensive clinical assessment, which involves history taking and laboratory exam. She listed down the kind of tests we do. In severe malaria, supportive care is very, very important. It involves triage, resuscitation of patients to stabilize them, because remember, severe malaria is an emergency. Then monitoring. This should be both clinical and nursing monitoring, followed by immediate response, immediate appropriate response. Then specific treatment is where we have injectable artesunate with the alternatives as artemether and quinine. I'll not overemphasize. Triage is majorly the identification of danger signs, and this should be followed with correct interpretation, because once you interpret a danger sign wrongly, then that means that you're going to manage a wrong complication, or you're going to do resuscitation for a wrong complication. So the interpretation of the danger signs, for example, a patient who is vomiting everything, what are these things that should come to your mind immediately? A patient who is in prostration, what should you be thinking about? Because then you'll think about things like hypoglycemia, severe anemia, and then once you manage them correctly, then the patient will be stabilized, but you have to continue monitoring them. And then, of course, specific treatment for lower level facilities, or if you realize that the kind of patient that is presenting at your patient is not you do not have capacity as a facility to manage, immediate appropriate referral is very important. And then to conclude it is that severe malaria is not complete until you've done follow-up for the kind of time that is recommended in the guidelines, given the kind of complication you're dealing with. History taking, in our guidelines, we are emphasizing fever. Here the duration and the pattern matters, because different diseases have different patterns of fever. Duration is because severe malaria is an acute febrile illness. So when a fever is more than 2 days, unless you're dealing with some of these parasites that cause subacute forms of malaria. In most cases, Uganda, we know over 90% of our malaria cases is because of P. falciparum. It's not so common that you'll have a fever due to malaria and P. falciparum for more than 2 weeks. So duration is something that should ring a bell. Associated factors, we have all these other things listed down here, but there are also other symptoms that could point to other comorbidities, but also to complications. Like, for example, we shouldn't take a cough in a severe malaria patient for granted. It could be pointing to something that is very important. We also have past medical history. Family history looks at, of course, in the past medical history, in this setting, you look out for immunization. Of course, when you're dealing with adolescents, you'll want to look out for mosquito net use, or find out if the house has been sprayed. But for boarding school, it may be a little bit complicated, because then now it's very important. It's very, very unfortunate that the patient or the patient that is presenting themselves to you may not be knowing if in their school they did some spraying, because this is something we want to reinforce for most of these boarding schools, to make sure that they spray the dormitories and the classrooms. Of course, the the physical examination. I don't want to dwell a lot on this because Dr. Chan, I think, elaborated this very well. Assessing for vital signs is very important, but also as you do this, you must also take the patient's weight, because remember, most of our treatments are weight-based. The danger signs is what we have listed down here. Current convulsions, unable to drink, but majorly as you pick these danger signs. And I think we emphasize to our communicators at the Ministry of Health to try and simplify these danger signs so that the parents can know them. For this case of adolescents, when you see an adolescent presenting themselves to you in severe prostration, be highly suspicious of a severe malaria. A severe headache in an adolescent is a key pointer. So we need to be looking out for some of these as danger signs that could be pointing to severe malaria, and we act very, very quickly. And of course, the systemic exam is also very, very important. I don't want to waste a lot of time on this because Dr. Jane elaborated this very, very well. Malaria is a systemic disease. It can affect all systems. So there's a tendency for most of our clinicians to simply take history and very, very minor history without being elaborate on the history taking and also the physical examination. And yet they are dealing with a disease that affects all systems. So it's very important that as a clinician, you examine every system whenever you're encountering a malaria patient, especially that one that comes in with some of the danger signs highlighted in the list on my left. So the other is to confirm malaria diagnosis, and clearly in severe malaria we got the WHO definition. You must have a positive RDT, but preferably a positive BS, because then in every severe malaria patient you must have a baseline BS, because as you're monitoring, this is you need to keep monitoring the level of parastemia and how it's reducing with treatment. So we usually prefer that the laboratory staff do not only do a thick film, but they should also do a thin film, because it's important in one, we need to first of all quantify the parasites, but also we need to do the specification of parasites. The recently concluded malaria indicator survey, we have picked that mixed infections have increased to a tune of about 18%, and we have malaria at about 4%. Of course, P. ovale and PVVAX are still less than 1, but we also know that mixed infections with P. malaria facilitate the fast progress to severe malaria. So it's important that we also emphasize that our lab technicians do not only do the thick film, but they also do a thin film. Urinalysis, of course, urinalysis is very important, especially the urine dipstick at the bench, because then it will in a patient who is having reduced urinary output and having reduced urinary output, chances are high that the changes in the urine dipstick will make you highly suspicious of an AKI. Complete blood cell count will show you a lot of things, including the comorbidities, but also the progress from maybe uncomplicated malaria or worsening severe malaria. Random blood sugar in case of hypoglycemia, renal function tests, blood culture and sensitivity, lumbar puncture, CSF analysis. If you remember clearly the definition of cerebral malaria, you must have done CSF analysis. Serum electrolytes are also very important, because metabolic acidosis is one of those complications that we encounter in severe malaria. While the RDT is a good screening tool, It will help you, especially in a patient who comes in, they have a negative slide, and yet the history has it that this patient has had malaria and they've been treated somewhere. In most cases, when you do the RDT, because the RDT is associated with persistent antigenemia, you will still pick a positive RDT and will know that this patient actually could have cleared parasites, but he was actually a severe malaria patient, and then you can decide on how you can resume or continue treatment. But in most cases, we prefer that we do microscopy for severe malaria. Of course, as you pick the danger signs, they help you to do what we call triage. You saw that in the lineup of treatment, we emphasize triage because currently the Ministry of Health is promoting the 24-2. The 2 is especially including this triage and the resuscitation. We should make sure that all our patients that come to us within 2 hours of arrival into the facility, they should have been identified and stabilized. It's very, very important, and this is when the triage comes in. You need to know whether this patient is already into severe malaria and they should be dealt with immediately, or you need to understand whether you need to prioritize them, or in severe malaria, it's not very likely that you can make this person wait in the queue. They will in most cases be in the emergency section. And some of these things, Dr. Jane mentioned them. Vomiting everything is one of the danger signs. Complete refusal to feed, especially in the
Jen?
children, severe pala.
Jen,
Yes,
you're left with 4 minutes, please.
Yes, and I want to really go through the complications management, cerebral malaria, and most of these are actually in the Uganda clinical guidelines. The ABCD has been spoken to by Dr. Jane. I really don't want to go into this, but positioning of the patient, management of convulsions, usually we want to start with rectal diazepam, and we usually recommend that you don't go beyond the 3rd dose. If the patient is not responding, then you need to consider moving on to phenobarbital. But allow me to mention here that the use of diazepam, I think we're going to revise our guidelines because we want to use better anticonvulsants that are actually not that so much sedative. Unfortunately, they are not on our essential medicines list, but once we put them in the guidelines, then they can be included on the essential medicines list, because what we want to achieve is better severe malaria management, and we save lives. Of course, for hypoglycemia, it's important to have a random blood sugar. Dr. Jane defined what hypoglycemia looks like. So in children, we usually will want to give 10% dextrose and for about 5 to 7 minutes. But after that, we want to maintain feeds via an NG tube, and this should be every 2 to 3 hours. It's important to also monitor random blood sugar because rebounds are very common. Then severe anemia, of course, group and cross match, and we will normally prefer that you give about 10 to 15 milliliters per kilogram body weight if you're giving red blood cells. But also you need to be cognizant of the oxygen saturation, because at times you may need to give this patient oxygen. Pulmonary edema, positioning the patient. In most cases, you'll want to prop up the patient, give IV Lasix, but also you've just heard from Dr. Bate's submission that I think that's why it's important for you to know your serum electrolytes as you're managing severe malaria. Metabolic acidosis, and of course here you must have IV access. You must give oxygen, sodium bicarbonate, and but it's important also exclude hypoglycemia, hypovolemia, and septicemia. Then of course for circulatory collapse and shock, we have literature showing that some of our malaria patients may have severe malaria and septicemia. It's important to know their blood culture. You have to really be aggressive in the rehydration, and we normally will prefer to use normal saline or Ringer's lactate or half-strength Daros. Renal failure, I'm not going to speak to that because Dr. Bate has spoken to it. Also, the fluid electrolyte imbalance, we know that you'll want, especially if it's starting with dehydration, you'll want to rehydrate using the Plan C, but then also you may need to be aggressive if there are features of shock. Respiratory distress, you want to, if it's metabolic acidosis, you want to manage accordingly. But if it's pulmonary edema or aspiration pneumonia, you may want to put the patient on oxygen. Hemoglobinuria or black water fever, this one is very common, especially in the adolescents. If a patient has not had a transfusion, it's important to rule out glucose 6-phosphate dehydrogenase deficiency. But the hallmark here is to transfuse and rehydrate the patient. Spontaneous bleeding, you'll want to give either fresh whole blood or fresh frozen plasma or platelets if they're available. Glasgow coma scale is very important as you're monitoring these patients, or blantyre coma scale. I don't want to go into this. I'll straight away go to the specific treatment. You need to quickly decide whether you're going to do IV, but I'll prefer that you do IVs in this patient. The limitation we have with in these patients, the limitation we have with our patients, and that is why most people are thinking that actually quinine could be doing better, is because of what used to happen with quinine. While we know that 5% is not fluid we commonly use for rehydration, but it was giving us a benefit. For whenever we gave quinine, we would give it together with 5% dextrose, and this would help, would give the patient some degree of hydration. And what happens with injectable artesunate is that you'll give a bolus of artesunate, and what most of our clinicians do is they don't bother to check the rehydration status of whichever patient they are dealing with, because the best practice would be if a patient can take orally, you encourage them to take in fluid, or if not that, you give them IV fluid as you concurrently do the artesunate treatment. The 7 steps must be followed. This treatment is weight-based. A patient that is below 20 kilograms, please note that the dosing is 3 milligrams per kilogram body weight. And the 0 hour, 12 hour, and 24 hour schedule should be adhered to. Another point where we mess up significantly is at the reconstitution. And what happens here is that most of us, especially the nurses that do give the injections, they don't reconstitute the drug properly, and they end up giving the patient a placebo. And then, of course, after dilution, the other stage where we mess up is the calculation of the dose of artesunate in mils. What happens is that we tend to give an underdose in most of our patients, because when it comes to the calculation in mils, we tend to give a lower dose. And then, of course, the scheduling is another area where we mess up. You find that someone gets another dose at 18 hours instead of 12, and someone comes after at 36 hours after instead of 24 hours. And then what happens also is that there is where you have to switch to the oral treatment, and there what happens is that people will quickly switch to the oral treatment even when a patient is not able to swallow, and yet we have that allowance of giving injectable artesunate until the patient is able to swallow. At times this really compromises the outcome of artesunate. Of course, like Dr. Jen mentioned, injectable artemether IM, and the loading dose is also very important. Is the alternative treatment, followed by quinine, and she elaborated on how we give quinine. I don't want to go into that. It's important that severe malaria patients, after being stabilized in the resuscitation room, they are either going to go into the intensive care unit or the high dependence unit. And these are the parameters we usually monitor: the vital signs, temperature, pulse, respiratory rate, oxygen saturation, BP, capillary refill. We also have level of consciousness, dehydration, pallor and edema, urinary output. And depending on what you find, you're supposed to respond instantly. with an action. And what happens is that in most cases we do pick some of this. Either we don't monitor the patients regularly. Some of the patients are admitted on the ward like other patients, yet they're supposed to be in the high dependence unit where you can closely monitor and react. And some of these responses that we are supposed to do delay, and by the time you come back, the patient is dead. So there's also level of parasthemia and then convulsions. And then for when you cannot manage the patient at a lower level, temperature control and convulsions control is very important. You're supposed to give oral sugary fluids for if you're at that very lower level. But if you can give you can give a bolus of either 10% dextrose, you can give that. Rectal artesunate for those below 6 years, and injectable artesunate for those above 6 years, or IM quinine. It's important that you do a test to confirm, but also it's also very important to write an appropriate referral and cancel the patient on referral and call the referral point. After, in case you successfully manage the patient and they are to go home, one of the things we do is smart discharge. Smart means that you are screening the patient for level of risk. Like a patient who has had recurrent admissions due to severe malaria, that is a high risk category patient. A patient who is coming from very far, a patient who is coming from a community where there is no community health worker, all these are high risk patients, and you should prioritize them and give them special counseling. As a patient goes home, the M stands for they should go home with medicine. Let's go stop the habit of telling the patients to buy the medicine. You need to see the medicine as a patient goes home. So on day 0, you're counseling the patient, but you're also giving them a referral for in case they were referred from a lower facility to you. So when they are going home, attach them to a facility where they can continue their follow-up. And then, of course, giving them a mosquito net is very, very important. The follow-up for severe malaria starts on day 0. We have one on day 7, and then we have day 14. And we have functions for each of those days. And then they come back on day 28, and that is when we start post-discharge malaria chemo prevention. Uganda picked the health facility model, and which they do together with the community health workers. So the follow-up is at the facility, because we realize that there are a number of things you need to check as this patient comes back before you start them on the post-discharge malaria chemo prevention. And the drug of choice is dihydroartemisinin piperaquine. So they do their dose 1 on day 28, and then they will come back after math for their dose 2, and then they will come back after math for their dose 3, and then you continue following them every 2 months until you make 6 months. But for patients of acute kidney injury and black water ntambira bano abantu abatalina mulamwa.
Dr. Jen?
Yes.
Dr. Jen Navgoza?
Can you hear me?
Yes, please.
Yes. Sorry, someone called me and interrupted me.
Okay.
And I submit chair. That's the end. Sorry, I rushed the presentation. But it's going to be shared. These are our guidelines for Ministry of Health Uganda.
Okay, thank you so much, Jen. So let's invite the last presenter, that is Dr. Andrew Damulira. Please go ahead and load your presentation. As you do that, I just want to make it clear that both presenters from World Health Organization and Ministry of Health are in agreement that artesunate is still the first line of treatment for severe malaria. Thank you, and over to you, Damlira, in the next 10 minutes, please.
Yes, thank you very much. I've learned a lot from the previous presenters. I'll be presenting about hemophagocytic lymphohistiocytosis and specifically I'll be presenting about the secondary hemophagocytic lymphohistiocytosis, which is malaria associated. By the time we get done, possibly we shall have a general overview and understanding of this complication that is considered to be extremely rare. So hemophagocytic lymphohistiocytosis is a life-threatening hyperinflammatory syndrome where you have an overwhelming self-sustaining inflammation that drives multi-organ failure and death, often if not treated appropriately. Often it's divided into two, the primary, or termed as familial, which is often seen in children where there are defects in certain proteins, genetic defects that make the body not to stop the inflammatory response, to dampen the inflammatory response. Often you have impaired natural killer cells and cytotoxic T cell killing activities. But in the secondary HLH, this is not, there are, of course, mutations that are associated with it, but often it's triggered by an infection, malignancy, autoimmune disorders, and it's predominantly in adults. However, it's also seen in teenagers, and it has been described in children, where a condition often is associated with an autoimmune disease or autoinflammatory disease or rheumatic conditions. That's when it's often described as macrophage activation syndrome. So in the disease process, often you have a trigger, which can be an infection, they can be viral, it can be malaria, it can be a malignancy, they can even be drugs, and these triggers will trigger inflammation. The infections will trigger inflammation within the body. And in some conditions, like for example, the primary one, you fail to clear the inflammation despite actually treating that trigger. In the secondary type, sometimes the inflammation that is triggered, for example, in those who are suffering from the infection for the first time, often it may exceed that threshold, where the body then goes into a self-amplifying loop of immune activation and it fails to switch off. It means you have sustained production of these inflammatory mediators, which are the interleukins and others, and they tend to trigger this massive macrophage hyperactivation. Our monocytes tend to mature into macrophages, and then these macrophages start engulfing the red blood cells that have been possibly affected. And as we heard from the nephrologist, this inflammation triggers injury to multiple organs, including the kidney. So you can have your blood levels go down, you can have your liver dysfunction, you can have coagulopathy, you can have central nervous system involvement. The study of these cytokines and all that has led to development of specific drugs that are directed to this. The familial one, which is often seen in pediatrics, we know that there are genetic defects where there's failure to dampen because of mutations in the perforin guanine enzyme pathway, and then you have unchecked inflammation. So what are the triggers? Specifically, we are going to look at the secondary HLH. The triggers often are infections. These tend to trigger close to 50% of cases of HLH. Among these triggers, often malaria has been reported, as we shall see ahead. Then cancer, often around 28%, and autoimmune conditions contribute 12%. In others, where the cause has not been ascertained, or in some other conditions, you may find that there's a 10% where you can't tell, but also drugs have been identified as possible triggers. So what's the presentation in this particular condition? In this particular condition, you have non-specific sepsis-like picture. You have your malaria patient, you think they have malaria sepsis, you think they picked up a bacterial infection. If you are sending your patient to ICU, cultures were taken off in the first day. But one of the things we see often, there are times your inflammatory markers, the CRP is very high, but the procalcitonin that is specific for bacterial is not that high. So among the presentations, you have these fevers. Despite treating malaria, clearing malaria, giving wide spectrum antibiotics, your patients still have these unremitting fevers. And when you look at your white blood cell count, your CBC, you tend to have a decrease. Cytopenias to the other people, you have cell lines that have decreased in simple terms.
Andrew,
yes?
you are left with 4 minutes.
Okay. Among the other presentations, there are neurological presentations like encephalopathy, seizures, and signs of meningism. You do a lumbar puncture, you do CSF analysis, you do a biofire, and there's nothing. We tend to have a hepatosplenomegaly and involvement of multi-organs, as we've seen, and often you tend to have rapid deterioration involving multiple organs. So in 2004, the Histiocyte Society came up with a criteria where they are looking at the 8 parameters. And in this criteria, they look at fevers, splenomegaly, cytopenias, in order to establish the probability of a person having a secondary HLH. In 2025, a new score came up because of suspicion of underdiagnosis or overdiagnosis. The H score came up, and it removed certain parameters, and variables. Often it's looking at is immunosuppression, temperature, organomegaly, cytopenia, ferritin, triglycerides, fibrinogen, AST, and if you do a bone marrow aspirate, you're able to demonstrate hemophagocytosis. So in this score, patients who score 169 and above, almost 90% of the time they have HLH. So in this particular case, you have a malaria patient, you've treated the malaria, you've given the broad spectrum antibiotics, you're thinking it's malaria sepsis. However, they are still spiking fevers, your organ involvement is just worsening. So in the last 1 year, around September, July last year, we struggled with one of the patients, Ugandan patient. And so at the end, we are able to make a diagnosis of HLH, and we are able to get the person out of hospital. So in the last year, we tried to find out among the very many patients we've admitted who likely have HLH, and we're aggressively screening for it. And we've so far diagnosed 12 patients. Of these, 7 were non-Ugandans, 6 were Chinese, 1 was German, and 5 were in Ugandans. Among the Ugandans, 3 were above 18 years of age, and 2 were less than 18 years of age. And what was important in all these patients, none of them had prior malaria exposure. Even the Ugandans, some of them were 21, but they had never suffered from malaria. And they all had multi-organ dysfunction where the kidneys are failing, the liver is failing, they are bleeding, sometimes elevated procalcitonin, CRP, and convulsions. And importantly, despite using broad-spectrum antibiotics, they still had persistent fevers. In their findings, in trying to identify what is the cause, we decided to screen them for HLH, and they all had markedly raised ferritin greater than 2,000, greater than 5,000. And those that initially had normal triglycerides, when we are treating them and they are deteriorating, when we kept on trending their fasting triglycerides, they were going high. They all had a high LDH, they had a hepatosplenomegaly, persistent fevers, cytopenias. So we decided to do the HLH criteria, and we identified some. And so in these that had persistent fevers, within 24 hours of starting high-dose methylprednisolone, the fevers resolved completely, the tachycardias went down, there was drastic improvement, and subsequently even the oxygen requirement, the FiO2 ventilator requirements went down. Among the Ugandans, some had extensive thrombosis, they were bleeding, and were wondering, is it purely DIC? Some of them had already been managed for DIC. We had liver dysfunction, 2 had a positive P anchor, and this actually tended to have a persistent AKI, progressive disease, and then discussion with a hematologist. Apart from the high-dose steroids, this received rituximab. We did plasma exchange for those who had acute liver injury with very high INR, but in so doing, it also helped us with a hyperinflammatory state. Those that had a positive P anchor, even in the follow-up, they had high ESR as high as 80, 90, 100, but subsequently everything normalized. 2 Ugandans were diagnosed on echo with malaria myocarditis, which still was treated, we used steroids and also colchicine. In that period, 2 patients were lost. One was referred to the national referral, and we followed up to find out, and that person was lost. And one, yes, we lost the person from IHK. Other Chinese survived, and the key mark in all of this, it was mainly giving them high-dose steroids after we struggled, realizing we had cleared malaria, we had covered sepsis, we are supporting all organs, but they had persistent fevers and deterioration. So why malaria and HLH? These two are very easy to confuse because the presentation is often the same: fevers, cytopenias, splenomegaly, marked ferritin. But to those, we used ferritin as a screening marker. And when you look up on data, ferritin has been used as a screening marker before subsequently you do other tests. It's often considered to be extremely rare, but there's documented reports, and I'm sure many other clinicians have possibly lost malaria patients who have persistent fevers despite cover. So we searched up on the internet to find out malaria-associated HLH, and there are 80 plus cases reported. In Germany, there's a cohort from over 13 centers, and that center was able to identify 0.3% in 1,461 treated malaria cases. However, cases from Africa were very few, possibly. Maybe we don't publish much of that data. So the question, overdiagnosis versus underdiagnosis. So to overcome, actually decide to do both the 2004 HLH criteria and the H score. But overdiagnosis, it means you predispose someone to giving them steroids, immunosuppressive drugs, which they may not need. But often you tend to monitor also. You tend to see your AST, your ferritin, which are commonly raised, but they can also be raised in malaria. Under diagnosis, often if you don't look out for this, you're likely to lose a patient despite cover and doing cultures which are negative. Often the hypothesis is that malaria antigens like the HRP2 tend to stay detected in the body for weeks, even after cure. So for people who have never suffered from malaria, this prolongs immune stimulation. The treatment, often you stabilize your patient, cover sepsis, organ support, as we've seen, try to identify the trigger, treat the trigger appropriately. If it's malaria, cover the malaria appropriately well. Corticosteroids are key, plus or minus, if patients don't respond. To those where it's refractory, you consider consulting when to give a toposide and do definitive therapy for this. The key takeaways in this: suspect it early. In case you've treated your patient, you've done cultures, you've done broad spectrum antibiotics, and they persistently have fevers, try to make sure you've covered the malaria in this particular case very well. You can still repeat your capillary blood DS to make sure you're not missing out on parasites. And yes, malaria can trigger HLH. If you suspect overdiagnosis, underdiagnosis, we decided for our patients to use both the HLH 2004 criteria and the H score, which increased the probability, and there are other drugs that were based on cytokines. If undetected, undiagnosed, you tend to have a poor prognosis. These are some of the references for us to use subsequently. Thank you.
Thank you, Andrew. That is quite new, and who knows, maybe this is one of the complications that the older children are actually facing once they get infected with malaria. So the presenters, you've all done a good job, and to the rest of us, I want to encourage you to attend the upcoming Uganda Pediatrics Association conference. It's going to happen in August, and we are going to be at Munyonyo Convention Center. That's in August 27th and 28th August, that is this year. So all these speakers and more are in stock. Please come and be there present so that you don't have to hear it from someone else. So we are going into our next phase of the agenda, and that is question and answer. Please raise your hand if you have a question. The questions that were put in the chat, Dr. Amtaire Maureen has done a good job answering them. So is there anyone with a burning question? Please raise your hand. Okay, let me check. Okay, so there are so far 4 hands. Yes, so we shall first listen to the 4 questions at once, and then the presenters come in to answer them. So we start with Chirabo. Frederick, please be precise. Thank you. Yes, Chirabo, Frederick, please unmute and ask your question. Okay, it seems it's having challenges unmuting. Tuha Marvin. Tuha Marvin. Dr. Achan, try unmuting them. Maybe they were disabled from being able to unmute themselves. Atuha Marvin. Dr. Chan, are you there?
Thank you so
Okay.
much for the wonderful presentation. My inquiry is about later there were updates about malaria vaccination, and you realize some regions are having malaria vaccine, some regions don't have malaria vaccine. What's the plan on that? Secondly, the malaria vaccine which is being given in Uganda, does it give enough boost or immune boosting against malaria? Because I was looking at the practicability of it being in some regions and not in some regions. Thank you.
Okay, then John Watch. John Watch, please unmute.
Yes, thank you very much for the wonderful presentation. I'm a medical officer up country here in northern Uganda. So I wanted to inquire something. 3 years ago, I also read a guideline from the MOH that outlined the smart discharge among other guidelines. And one of them that I wanted to inquire, they had said that the OD dosing of artesunate after the 3rd doses was already obsolete and not used. And in that guideline, they had said that if there is no clinical improvement at 24 hours, OBS is positive, we consider IV quinine in the dextrose, not the once daily IV artesunate. So I also wanted the consultants to guide us there. Thank you.
Okay, so your question is about dosing for artesunate. Okay, then Angela Mirembe. Mirembe Angela.
Yes, thank you so much. I'm a pediatrician. My question is especially on the dosing of IV quinine when you decide to go to second line. I've seen some people give the quinine give it 8 hourly for the first 24 hours, then do OD subsequently, then some continue with 8 hourly. So my question is, what's the right dosing and for how long do we give the IV quinine? It would also be nice to elaborate now on when do we switch to a second line anti-malarial. Say if I have a child with BS 3+, after that 3 doses of artesunate, maybe the BS is 2+, they're not yet able to swallow. So when do I decide, do I go to quinine? Do I still stay with the artesunate? And yeah.
Okay, thank you. Dr. Chan, please take on these 3 questions. The first about the vaccine.
Sorry, may I raise my question? I was unmuted at first. This is Mika.
Okay.
Okay. Greetings to everyone. I appreciate the efforts given. I have two concerns to raise today. The first one, I had in the chat they said that those people who are in drug shops and maybe they are having issues with the proper treatment of malaria, and they said they're working with NDA and other agencies that all these things are put right. There is a concern at I'm the in charge. I'm working in my UK St. Camilla Center 3, but we have a challenge that out of 10 malaria cases diagnosed with ABS, if both tests of BS and MRDT are done, you may find that 5 or even 4 out of the 10 tested with RDT show positive. Others, they show negative, but when you do ABS, they have either a +2, a +3, or even a +4 parasitemia. So these other colleagues of ours who are working in drug shops and clinics which cannot afford to have microscopes, how are they going to be helped to handle such a challenge? The second issue that it raised is I have had several cases here of patients who are stable, not having hyperparasitemia, but you give them first line oral treatment for malaria, it fails to clear the parasites. You go to second line, that's DP, it still fails. And I've even had cases whereby they completed maybe like 3 doses of artesunate, sometimes even QNN, and you even give them orals. But after like a week or 2 weeks, you test and still parasites are not clearing. What would be the challenge, even when the right doses are given and everything is followed in the right way? That is my concern. Thank you very much.
Okay. Thank you. Dr. Achan, please take on these 4 questions from the 4 people that asked.
Yes, Elizabeth. For some of the MOH specific questions, I would request Dr. Jen Nabakoza to chip in.
That's
I will
okay.
cover a few, and then, I think there are some issues related to an MOH addendum that the ministry would need to clarify on. So I will start with a question on IV quinine and the administration, and then I think the statements that have been repeatedly mentioned about 3 doses of IV artesunate. So I think the general guideline is that we start with a loading dose of quinine and then step down to 10 milligrams per kg. And the idea is that parenteral treatment is given until a patient is able to tolerate oral therapy. So we are monitoring the parasitemia and the parasite count declining over time, but the clinical aspects of improvement are also critical to mention. So the critical recommendation is you provide the parenteral drug until the patient is able to tolerate oral therapy. And for IV quinine specifically, like we mentioned earlier on, if the patient needs IV quinine for longer than 48 hours, then we step down the dose to 1/3 of the original dose. In many clinical settings, that's stepped down to the 10 milligrams per kg, provided twice a day, but the general guideline is step it down to the step it down by 1/3 of the original dose. Now, the issues around IV artesunate, and I think this is a common cause of confusion of 3 doses. So 3 doses is not a prescription. What WHO says, and what the Ministry of Health also says, is that you give IV artesunate at the recommended doses until a patient is able to tolerate oral therapy. If your patient is able to tolerate oral therapy within 1 day or after the first dose, please maintain the injectable for a minimum of 24 hours, but continue treatment until the patient is able to tolerate oral therapy. So let's remove this idea about 3 doses being the maximum amount of dosage that a patient who needs IV artesunate should get. I think that that's something that has been repeated in our communication, and I hope that we can clarify that and have clarified that a bit better in this session. On the mix between artesunate and quinine, please, Jen Nabakoza, do mention that, because I think that's closely related to decision making at the Ministry of Health. Now, the issue around diagnostics, the differences between rapid diagnostic tests and microscopy. As we've mentioned, microscopy is ideally the gold standard, and there are challenges in that some of the health facility levels do not have the microscopy, and RDTs are indeed also standard of care. There are issues around RDT if you're having your RDT in a drug shop, how are you storing the RDT? They may be a negative, but they may also be negative because of the quality of the diagnostics test and how it has been stored. The other emerging global challenge around RDTs is the issue of HRP2, 3 deletions. That most of the RDTs that are currently in use are based on a parasite protein that is called HRP2 and 3. So in a few of the cases, it may be because of HRP2 or 3 deletions. But in Uganda, the surveillance that has been done today does not show that that's a significant problem. So around RDTs, there are issues around storage, there are issues around how the RDTs are being used. But if in doubt, please repeat the negative RDT with a microscopy. And that's why it's important to then get the referrals. So you do not stop at the drug shop. If you're in doubt as a result of the test, based on the clinical, picture that you have, please refer that patient to a center that can actually provide a good quality diagnostic microscopy or otherwise. Jen, if you could respond to the earlier issues around IV artesunate versus IV quinine, I think that would be good. Thank you.
Dr. Navakoza, did she drop off? She seems to have dropped off.
I mean, if she's dropped off, I think I will say that according to the WHO recommendations and the latest clinical guidelines from Uganda, that addendum that was sent out at that point in time did not include some of the global guidelines. So the recommendations as we've presented today is that you give IV artesunate until the patient is able to tolerate oral therapy. It's important to track parasitemia, but the ideal in terms of switching from injectable to oral is the clinical improvement. And remember, even when you transition to the oral therapy, the oral drugs that we are providing these patients are very efficacious and they should be able to clear the remaining parasitemia. So parenteral therapy, yes, you're tracking both, but the decision to switch to oral should be based on the ability of the patient to be able to take the drugs. Completion of parasite clearance happens with the ACTs that you have provided. And I hope that provides that global guideline. There are questions around the malaria vaccine. I don't know if Maureen, you're on. Maureen Amutuhaire, would you want to answer that if Jen is not on the call?
Jen is back. She just
Jen,
needs
okay.
to, yes, you enable her to unmute.
She should be able to unmute. Let me just see. Jen, you should be able to talk.
Yes, yeah, I was muted. Okay, regarding the malaria vaccine, we need to appreciate that we need to appreciate that currently we have inadequate supply of the malaria vaccine, but we're also being guided by evidence. The malaria vaccine is more efficacious in the moderate to high transmission zones, and that's what most countries were guided to do. They were guided to prioritize the moderate to high transmission during the malaria vaccine rollout. And so the regions that don't have, the districts that don't have the malaria vaccine, because they're located in the low transmission, we are trying to advocate for, because the Uganda malaria situation is unstable, we are trying to advocate for a total rollout of the malaria vaccine. But I think we've been given a condition that if we are to do that, we are supposed to support the malaria vaccine introduction as a country using our domestic resources. And that is what we are working on as a country to make sure that we have the vaccine everywhere. But for now, we can only roll out the malaria vaccine in the moderate to high transmission. However, anyone that feels that they need to benefit from the malaria vaccine, as long as the child is below 24 months, that's 2 years, or if they have started and they are still within the age range of below 5, it's available in the private sector, or you can move to a nearby district where we have the vaccine. So that's the position when it comes to the malaria vaccine. quinine versus artesunate. Usually as Uganda, we usually follow the WHO guidance. And then, of course, we are also informed by the results that come out from our therapeutic efficacy studies and the different studies that are being done. So far, what we have clearly shows that artesunate is still effective, and it gives better results. We're still making reference to the Equamat study, where we know that when they compared the arm that was using artesunate compared to that was using quinine, we had quicker resolution of complications in the arm of artesunate. We also had reduced mortality associated with the use of artesunate. And we've so far not gotten any literature that points to a failure associated with the use of artesunate. And clearly, what comes out from the different literature is provider practices, and therefore, as a country, what we're trying to do is to make sure that those practices are corrected. But also, I think in the long run, we are planning to use the better brand that does not require the step of reconstitution. And then, of course, what will be left is to ensure that the providers are giving the right amount of meals. But artesunate remains the preferred option for treatment of severe malaria for Uganda. And until we have a clear justification, I know that currently our guidelines are speaking to when you give zero dose, you give 0 dose and 12-hour and then 24-hour. You're supposed to repeat a slide and do a clinical assessment. But before you do all that, you're also supposed to check was the reconstitution done right? Did we give the right dose? Did we give the right dose in terms of milligrams and mils? And then you can also check. And then when you do the clinical assessment and parastemia and realize that, okay, the parastemia is reducing, but the clinical picture of the patient is not better, then you're supposed to continue injectable artesunate to a maximum of 7 days. But you have to remember that artesunate is a monotherapy. So even if you do 7 days of treatment, you're actually supposed to continue with an oral ACT. So the Uganda position is that if the repeat BS at 24 hours is still positive, you and you've checked that you've given the right dose, the reconstitution was right, then you are supposed to change then to quinine, because then you know that the treatment has failed. However, we're likely to change that because there is also literature coming through indicating that there is delayed parasite clearance, but eventually the parasites clear. And we want to change, and we change to the fact that after you change to quinine after 48 hours. But of course, that has to be with after discussion with the clinicians, because the clinician's point of view is that normally when you do those additional days, when there's this increasing parastemia and there's this persistent parastemia, you risk losing the patient. So for now, our Ugandan guidelines are that after 0-hour, 12-hour, 24-hour, after that repeat BS, if the patient has not improved in terms of level of parastemia, for example, the baseline parastemia has persisted, clinical picture is getting worse, or the baseline parastemia is getting worse, then you're supposed to change to injectable quinine. But even when you change to injectable quinine, the other confusion is around, so when you're done with injectable quinine, what happens? There are some teams of clinicians who think that after quinine, if you've given quinine, then you're supposed to do oral quinine. I want us to note that if you've done injectable quinine, the position is that you're not supposed to continue with oral quinine unless you're going to do it together with clindamycin. And currently, our essential medicines list has no clindamycin in it. unless you're going to tell patients to go and buy. So the ideal is that you start a full course of an ACT, preferably a dihydroartemisinin piperaquine. Or if you feel that in your assessment, the patient had already tried dihydroartemisinin piperaquine and the preferred brands, because the number of brands on the market, but there are those that are known to be very good brands. And you feel that the patient is not improving, then you can switch to artesunate pyronaridine. And I think that is the clarity I wanted to provide. But before I go off, I also want to clarify on this issue of there's someone who talked about first line and second line. Kindly note that from June, from 1st of July, the country has started the multiple first line treatment. So we no longer talk about first line treatment as artemether-lumefantrine. We have multiple first line treatments by level. So level 2 and community, their first line treatment is artemether-lumefantrine. Level 4, their first line treatment is dihydroartemisinin piperaquine. Level 4 and above, that includes the general hospitals, that includes the regional referral hospitals, national referral hospitals. There we are doing artesunate pyronaridine. The question is that in case artemether-lumefantrine fails at that level of health center 2 and community, what does one do? What you have to do, because remember, whenever a treatment does not give you the desired results for uncomplicated malaria treatment, you are regarded as a suspected treatment failure and not a case of anti-malarial resistance. At the clinical level, what you pick is suspected treatment failure. So health center 2 and community will not be able to take off a dry blood sample. So we are encouraging one, and they're also not doing microscopy because treatment failure is confirmed by microscopy. So you refer to a high level, and that high level already has dihydroartemisinin piperaquine, which is the second line, which is the alternative you give in case the artemether-lumefantrine fails. Literature has it that dihydroartemisinin piperaquine is still a very good drug compared to artemether-lumefantrine. So in case dihydroartemisinin piperaquine fails, which may be very rare unless the brand you're using is not very good or you're not giving the right dose, because what we have with some of our clinicians is that they are not correctly dosing dihydroartemisinin piperaquine. They are giving everyone 3 tablets. Yet we know that anyone above 50 is not supposed to be getting 3 tablets. So you give, then in case dihydroartemisinin piperaquine, the alternative you give is artesunate pyronaridine. So please note that right now the country is doing multiple first line treatments. Why multiple first line treatments? You're no longer giving only artemether-lumefantrine that we've been using since 2006 to date, 20 years down the road. We've mounted a lot of pressure on it, and we're trying to reduce pressure on it. So what we have now are multiple first line that are available at different levels of care. So each level of care has their own kind of first line treatment. I think that is it. The other one of RDTs and storage, I think Dr. Jane Chan has spoken well to it.
Yes,
I think those
that's
are the
right.
issues. Yeah, thank you
Yes,
so much.
that's right. It's already a timer, but I'm seeing some more hands up. So let's use the next 10 minutes to wrap up. So the next people I select to ask your questions, please be precise, or else I'll be forced to cut you short because time is not on our side. So Jonathan Sechito, please ask your question. Okay. Jonathan is going off. Jackson Sewanyana.
Yes, good evening to you all. I'm Sewanyana Jackson. I'm a journalist with the New Vision Wicked Print. For me, hello?
Yes, please, go ahead.
Okay, I'll just make a request because I was requested by the editor to come and attend and then see how we can get something to write for our audience regarding this severe malaria and its management. Now, I'm making a request for the contacts of these three presenters, Dr. Jane Nalakoza, and then Dr. Anthony Bate, and then finally, Dr. Andrew Damulira. If I can be shared with such contacts, such that we can have a separate engagement where we can have something that can zero down to our audiences of Buked. Thank you very much.
Okay, thank you. And we welcome the media as well, because we need you to spread the news far and wide. Please drop your contacts in the chat for Dr. Amthaire Maureen to capture, and she'll reach out to you. So make sure she has your contacts, Dr. Amthaire Maureen. Is that okay?
Moment, you mean I just share my contact in there? I will be helped with the contacts?
No, put your email address so that Dr. Amthaire might capture it and she'll reach out to you after the call.
Okay.
Yes.
Yeah.
David Babazi? David Babazi?
Yes, good afternoon to you all. Thank you very much. I am not a media practitioner. I am just a concerned parent. But I'm not a medical practitioner. I'm a concerned parent. First of all, I just want to thank you all for the wonderful work you've done. My question, number one, is there a new strain of malaria? That's my first question. My second question is, what is the relationship between malaria and blood groups? Because just need to be helped to understand. The third question is for the medical practitioners here who are actively involved with providing medical services to children who are in boarding schools. How are you going to help us translate this very detailed information in a manner that will help avoid and manage and bring down these malaria cases that have become a big challenge? I thank you all for the work you're doing, and may the Lord bless you all. Thank you.
Thank you, David, and thank you for representing the parents. Yes, Andrew Oriel.
Good evening, all. My name is Andrew, chairperson of the Uganda National Pediatric Nurses Association. My question is on multiple first line. The presenter said as if the coatem is going to be used in health center 2 and community, of which they will be doing for us the RDT. Does it mean that 3 and above, the RDT is going to be wiped off, or because there are other people who comes direct to the center 3 and they jump center 2, maybe 3 is near to them? And also, how do we capture it, like somebody said, people who are in the clinic, the drug shop, of course they do RDT. Which other arrangement will they be offering to the community? Because some work as medical water center like that.
Okay.
Thank you.
Thank you. Thank you, Andrew. Colleagues, I ask that you ask one question. We've run out of time. So I'm going to select 3 more hands and we shall call it off. Okay. So Stephen McMott.
Yes, thanks a lot. For giving me the opportunity. I really wanted to inquire about the use of doxycycline and clindamycin in the management of malaria. Thank you.
Okay. Isaac Ochela.
Yes, thank you very much. I would like to thank Dr. Chan for the presentation. My question is, I'd wanted to know whether the Ministry of Health has gotten any relationship between the malaria surveillance among patients who had COVID-19. Because in most cases, we have had patients who were infected with COVID-19 frequently getting malaria attacks as compared to those who didn't get the COVID-19 infection? Thank you.
Okay, and then lastly, let me choose a lady. Evelyn Ndengemu.
Yes, my question is on one of our last presenter who was presenting about the HLH. Yes, concerning the high dose methylprednisolone that we give in such patients with such a condition. I'm looking at a case in a point where our patient has a complication, one of the organ damage, like we have a AKI in amidis. How safe is it giving that high dose methylprednisolone? Then secondly, about a resistance profile, you say there's no evidence of, I didn't hear well maybe, about the resistance in artesunate use, but I've encountered one of our patients whereby every time she becomes sick of malaria, never gets well, is never well with artesunate IV and is always responding well on quinine.
Okay.
So I don't know. Yes.
Okay, thank you. Of course, the hands cannot end. Sorry about that. So we shall just address these questions and then wrap up. So let me request Jen. The questions that were raised by David Babazi, a representative of the parents. He's wondering, is there a new strain of malaria? And what's the relationship between malaria and what?
And blood group. Which of the two gens?
Oh, Jenna Chan. And then a
Okay.
message to schools. What message should
schools.
we give to schools and how should we package it? Thank you.
Yes, thanks. I think we will divide this between myself and Jen Navakoza. But yeah, I think just to mention, there's no new strain of malaria. I think what we are seeing is that children who are relatively having low previous exposure to malaria and essentially have low immunity to malaria are presenting with severe forms of malaria in a way that would not have been expected of that age. So there is no new strain of malaria, but we are beginning to see newer or unique severe manifestations of malaria in a number of children, especially in the old age group. Is there something we can do about that? Yes, there's something we can do about that. Like we mentioned, it's important that we recognize that older children need to be covered with malaria prevention measures. In the schools, there are programs right now that are looking at malaria prevention in school-age children, and I do know that the ministry is picking this up as an important area of interest. We do IRS or indoor spraying in homes. Should we be focusing as well in doing this in the schools? We've emphasized sleeping under mosquito nets in our homes. Do we have mosquito nets in the school? So there is a call for a focus, not just on treatment in school, but generally, how do we prevent malaria in these children who are living in school, likely boarding schools, and may not have access to the prevention that they have in their homes? So there is no new strain, but we are beginning to see a population of children who have low immunity to malaria, getting infected with malaria, and quickly presenting with severe forms of malaria, and that has to be addressed. What do we intend to do in the context of schools in terms of medical care provided in schools? I would hope that Jen Nabakoza would answer this at the level of the Ministry of Health. But I think even as Uganda Pediatric Association, the school-based program has been something that is keenly of interest to us. And this is a time that we will sit together and begin to look at how best should we approach and provide support to the medical care being provided at schools. Do we need to do training? Do we need to ensure that there are protocols that are being provided? Essentially, how do we ensure that there is early recognition and rapid access to care? Within 24 hours of illness, everyone should be having access to malaria treatment and care. So I hope that answers that, but I would ask Jen to also provide some addition to that. One other question that was raised, that we've actually done a study to evaluate on whether there is a higher incidence of malaria in people who have had COVID-19 in the past. What we have found in a study that we really completed in October last year, we compared people who had had COVID-19 and those who had not had COVID-19 before. And what we found was the reverse. The risk of malaria was largely much lower in those who had had COVID-19. But there was a reason for that. Because of the experience of COVID-19, people were more careful. They sought care earlier. They were essentially using preventive measures better than those who had not had COVID-19. So that perception that COVID-19 may be driving a higher burden of malaria has actually been found not to be true in a study that we just conducted across several districts in Uganda. The issues around the multiple first line and whether the use of doxycycline and clindamycin, I would request Jen Nabakoza to respond to those. Thanks.
Okay, thank you. So Isaac Ochola, your question has been answered. And likewise, some of the questions by David Mbabazi. Jen Nabakoza, please be precise. Thank you.
Yeah, like rightly said, there's no strain, but the issue is the previous non-exposure and therefore the low immunity. And that is why like you had the different presenters, including Dr. Andrew. That's why these patients are presenting differently. Clearly, some of these patients are coming from Kampala, where the transmission is very, very low because of the heightened preventive measures. And some of these children have never had malaria in their entire life. So when they do get exposed to these parasites, even when the strain has not changed, they present differently. The association with blood group, I don't have any information on that. Dr. Jen maybe will come down back and speak to that. We have a well outlined plan on how we are going to train
Jen, we're
our
having an echo.
problematic areas. Our problematic areas, for example, private sector. Private sector includes drug shops. We have simplified information to reach them. Apart from the national guidelines, we have simplified protocols and job aids, mainly in pictorial form that can easily be understood by this group. All we have to do is disseminate through
Jen, we are having
training.
an echo.
I don't know where the echo is coming from.
You could be using two gadgets.
No, I'm using one. I'm
Okay,
actually using one.
It's now fine.
Yeah, so we have a plan to train all school teachers, and then of course for those school nurses, for where they are available. For where we do not have school nurses available, we want to train the school health. I mean the senior women teacher and senior men teachers. Since we can train a VHT, we can give VHTs basic information, and they do a good job with proper oversight and continuous follow up. We are going to make sure that we have someone with capacity to give the basic care for malaria case management, but also prevention in every school. It's a tall order, but it's something we are going to embark on. And we're going to start with where we are most affected, like the metropolitan Kampala. We can't do this alone because this platform of school is housed elsewhere. We are collaborating with the Division of Adolescent and School Health, supported by the UPA. So we're going to reach out to the schools. And the addition of clindamycin and doxycycline to quinine as maintenance treatment. Of course, we are looking into a number of issues. At this time, when we are trying to reduce cases, fight resistance, and make sure we have better outcomes so that we have zero malaria deaths, we consider a lot of those treatments where compliance with the treatment is very costly. So when you look at clindamycin, it's costly too. You have to do it for a long time. If you're doing it with quinine, that's about 7 days. Compliance will be compromised. So we don't want to appear as if we are not cost effective. So it's not something we are considering in our guidelines, and that's why it's not in the essential medicine list. And then also doxycycline. Doxycycline, especially for our children here, it's not something we can easily run to, because that means all your clients 12 years and below will not benefit from this. So doxycycline, we maintain it under prophylaxis for older people above 12 years, but not as part of maintenance treatment given together with quinine. Our guidelines are the way we have spelled them out. We are mainly using ACTs for now, artemisinin-based combination treatment. We know the ones that have challenges, we are trying to reduce pressure on them and working more with those that have proven to have less resistance markers in terms of burden. So I think that answers the question. I submit, Chair.
Thank you. Dr. Damulira Andrew, please respond to the question from Evelyn Dengemu regarding prednisolone use in HLH.
Yes, thank you very much. You can use even other steroids like dexaprednisolone, but you don't have to worry much about the dosing because in this particular case, the driver for your multi-organ involvement, your multiple organ dysfunction syndrome is actually the inflammation. So the moment you give the high dose steroids, it should often dampen all that and help you get better. In renal disease, I wouldn't want to comment because Dr. Vate was here, but he gives higher doses of steroids than actually we give in some conditions. Often no need for renal dosing in renal disease. Thank you.
Okay, so thank you very much, the presenters and Dr. Ntaire Maureen, who answered the chat questions, and the audience, the wonderful audience. We had over 1,500 participants in attendance. So that was, this was well attended. And we urge you all to register and attend the upcoming Uganda Pediatrics Association conference. Like I already mentioned, it's going to happen in August 27th and 28th. And to be a physical event that's it's going to happen from Speak Resort Convention Center, Munyonyo. There is more that is going to be discussed, including issues surrounding malaria. So please come and learn more and interact with different experts one-on-one, okay? And then also follow us on our Twitter handle, which is now X, that is Uganda Pediatrics Association, for more information pertaining matters of child health in Uganda and much more updates as you see fit. So please follow us on our Twitter handle or X handle. And we thank you all and have a good evening. Bye.
Bye-bye. Thanks, everyone.